Hello, everyone. My name is Elizabeth Montgomery. I'm a pathologist at the University of Miami, and guess what? Miami. I'm going to be doing a series of 12 lectures. This is the first of them, and it's going to be sort of general topics, and then we'll circle back to some of the same things. But you'll get a little bit of repetition, but then with a new angle as we recycle the topics. And let's get started with upper gastrointestinal tract biopsies. So we'll kind of go through a simplistic approach that can be consistent in the upper tract. I'll point out a few rookie mistakes and artifacts and pitfalls, and we'll come back to some of those as we look at individual areas. So what's considered upper? The esophagus, the stomach, and the small bowel. Generally, what we see in biopsies is the duodenum because that's accessible. When the colleagues really push themselves, they can reach the jejunum, but it's a bit of a project for them. The important thing about the upper tract is that remember that the lamina propria is abundant in lymphatic spaces, and this is not the case in the colon. So that if a cancer invades the lamina propria, it can be classified as T1A, and it doesn't usually result in metastases, but it can. Whereas metastases are highly unlikely if there's invasion of the colon lamina propria, and it's considered TIS. Now, in the esophagus itself, a lot of us kind of don't think about the lamina propria, and esophagus biopsies often lack it because, of course, when normal esophageal mucosa is sampled, it's very slippery and very hard to take a bite of. So if you see lamina propria in esophageal biopsies, it often means there's something abnormal or reactive or injured, but don't mistake it for submucosa because, of course, that can lead to errors in determining depth of invasion if you have an early carcinoma. So we tend to see it when there's, esophageal Crohn's disease or some kind of other inflammatory process. All right, so this is what we often see in a biopsy. And what I'd like to point out is that the basal thickness is not very much. It's only like 3 or 4 layers of cells, but remember, it doesn't really count around the papillae, so this wouldn't be a thick basal layer, it's just a slender one around a papilla. The papillae should only go about a third of the way up, as we see here. Of course, it can be really tough when biopsies are tangentially embedded. And this is from a resection. It's not a very good slide, but it shows us the features we need to see. This is our epithelium, our lymph. Hey everybody, this is Elizabeth Montgomery. This is the fourth of 12 gastrointestinal pathology sessions, and this one concerns gastric carcinoma. And we'll talk a little bit about biomarkers and what's new there. And let's get started. All right, so we'll talk a bit about gastric carcinoma, but I'm also going to show pitfalls first. And just to remind ourselves, let's go back to the basics as we have several times. This is just a, oxyntic stomach. And just to remind ourselves, this is oxyntic mucosa. The chief cells are down below. And here's our submucosa. The vessels start to get bigger here. This is when metastases get easier, even though you can have them from lamina propria. And here's our muscularis propria. Let's remember that our antrum has different morphology and different things happen there compared to the body. So here we are in the antrum with specific type antral glands here and our pits here that the gastroenterologist sees. And remember, of course, that it's normal to see G cells in the antrum that make gastrin. And also in the antrum, we see D cells that make somatostatin to counteract the vagaries of gastrin. And here is a gastrin stain. And you can see the G cells very well. But actually, in well-preserved tissue, you can see the G cells quite nicely on H&E. I've indicated one, but let's see, here's one, here's one, here's one, here's one, and here's one. So sometimes you can see them really well, and that's your proof of being in the antrum. This is a nice example of an abrupt transition between transitional mucosa and oxyntic mucosa. So we have a little bit of a antral type gland here, but there are a few parietal cells, and then we pretty much go right into oxyntic mucosa here. And of course, this is kind of classic oxyntic mucosa. All right, so that's what lives there. Ah, what's going on here? Well, this is not in situ signet ring cell carcinoma. This has just been called vacuolated cell change years ago by Carlos Rubio. And basically, you just see all this weird vacuolization of the specific glands in the stomach. In all likelihood, it relates to proton pump inhibitors many times, but this is not what in situ signet ring cell carcinoma looks like. Here's more of it at high power, and it's really affecting us. Hi, colleagues. I'm Elizabeth Montgomery, and this is the last of the sessions, and it is time to end with the anus. So if I haven't mentioned before, I do have disclosures. I do consulting for several instrument companies and some pharma companies, but it's really not anything to do with what we're talking about. All right, so for the anus, we're going to differentiate common benign conditions that can be confused with other things. And we're going to look at some important facets of anal neoplasia, including some benign conditions that can mimic neoplasms. So let's go to the basics. The anus is short. So for example, a biopsy from the anatomic anus could actually contain glandular, transitional, or even squamous mucosa. So you can have a biopsy that's labeled anus that shows colon type mucosa, and that is not necessarily labeled wrong. Anatomically, of course, the anal canal begins when the rectum enters the puborectalis sling that can be felt as the anorectal ring if you put your finger up there, and it ends at the squamocutaneous junction. And that's called the linea anocutaneata, or cutanea, sorry, with the perianal skin. And of course, the upper 2/3 come from endoderm and the lower from ectoderm. And the dentate line is where the two of them meet. And all of those things are labeled in this lovely diagram. All right, so this is anal transitional mucosa, and this is where problems happen. And of course, the body doesn't like transition. So think about like Barrett's. You tend to see your issues right at the junction of the squamous and columnar mucosa. And here you see something that looks like on the bottom, like it's kind of squamous or kind of almost like urothelium, hence the term transitional. And then, of course, there's this columnar stuff on top that looks a bit glandy, but it doesn't look like colon glands. So this can be a trouble area on tiny biopsies. So this is a beauty contest, and we have just normal anal transitional mucosa taken at the same magnification as a high-grade squamous lesion. And you can see that it just, if something's embedded funny, there's a little overlapping here in the normal stuff. So I know I find myself confused sometimes, but there's a lot of overlapping in this intraepithelial neoplasia or dysplasia or SIL, whatever your favorite term is. Another thing down there is the anal ducts and glands. And these are little tubules that are kind of like our transitional mucosa, but there tends to be a cuff of lamina propria right